So good evening, everyone, and welcome to the ESE Talks Nurses. And we will talk about insulinomas today, and welcome everyone again. We will talk about insulinomas for approximately 1.5 hours, including presentations, and the question and discussion will be at the end of the program. So please ask your questions throughout using the Q&A button at the bottom of the screen. We will not be monitoring the chat box for questions. They are only for relating to the presentation. So please ensure use the Q&A box throughout the session. For technical or administration questions only, please use the ESE team, the chat box. They will answer that. So this session is being recorded and will be available on the ESE website as soon as possible after the session has concluded. I was already informed that tonight we have an audience probably of about 80 participants throughout 32 countries. So hopefully you will all be here this evening to join us within this talk. For the ones who turn in later, please ask your questions throughout the session using the Q&A button. And the chat box will only be used for technical questions, so don't use that for Q&A. Use the Q&A button. So as you can see, we will start with a welcome introduction by me. That's already done. And then an insulinoma talk with Professor Simona Glasberg. And then the role of the nurse caring for patients with insulinomas with Alden Stua. And after the two sessions, we will start a Q&A and discussion. And at the end of the talk will be ended at 7:30. So I think we can start with the introduction of our first speaker. This will be Simona Glasberg from Israel. She is a specialist in endocrinology and internal medicine, but most of all in the endocrine oncology. And she is the head of the Neuroendocrine Tumor Unit, European Neuroendocrine Tumor Society Centers of Excellence, in Hadassah Medical Organization and the Hebrew University of Jerusalem in Israel. She's included in many committees and guideline groups and has won several accreditations. So we are very welcome, Professor Simona Glasberg, and very happy that you will present here your slides. So please, the floor is yours.
So thank you very much indeed, Wanda. And it is a great pleasure for me to be here with you on this evening. Thank you very much indeed, you organizers, ESE, and the Nurse Committee of ESE for the kind invitation to discuss this evening on insulinoma, different aspects, starting from the benign insulinoma and also going through the malignant counterparts of this disease. These are my disclosures. So following a brief introduction into the universe of neuroendocrine neoplasms and mainly the gastroenteropancreatic ones, I will take you with me into the world of insulinoma, highlighting mainly the need for high suspicion index in our clinical daily practice to identify and treat these patients. And then I will end with a couple of patient cases from my clinic, and then I will summarize. So very briefly, neuroendocrine neoplasms are very challenging. They are heterogeneous. They arise from a variety of cells that are dispersed throughout our body, so-called the neuroendocrine or enterochromaffin or enterochromaffin-like cells. These tumors are diagnosed with an increasing incidence by recently published data from SEER database from the States. Practically, we are reaching about 7 new patients per 100,000 population per year. Most of these tumors belong to the well-differentiated group of tumors. Most of them develop sporadically, but about 10% at least inside familial syndromes, as you know, such as MEN, VHL, tuberous sclerosis, etc. Most of these tumors develop inside the gastroenteropancreatic area, and about 2/3 of them, they are already metastatic at the diagnosis time. And today we have a variety of therapeutic options that have to be discussed in a very detailed manner inside multidisciplinary team by specialists in expertise centers. Also, these tumors present a clinical challenge. Although they are called neuroendocrine neoplasms, in about 2/3 of them, these patients do not secrete hormones. So they are diagnosed either incidentally due to other imaging, for example, performed for other reasons, or because tumor mass-related symptoms such as pain, jaundice, nausea, vomiting, weight loss, etc. And in only about 25%, these patients come to see us because of hormonal hypersecretion-related symptoms, as listed here, between them insulin produced by insulinoma, gastrin by gastrinoma, glucagon by glucagonoma, etc. Also, the functioning neuroendocrine neoplasms patient can present with tumor mass-related symptoms in parallel with the hormonal hypersecretion ones. And importantly, as you will see in one of the cases that I will present today, in about 10%, the patients with non-functioning tumors develop functionality during their life with the disease. And usually this change in the behavior of the tumor is associated with a worse prognosis. The synthesis of a variety of amines and peptides is a special feature of neuroendocrine cells, and usually at least 20 single hormonal markers have been described in neuroendocrine neoplasms, such as listed here, glucagon, insulin, etc. And rarely multiple or secondary hormonal secretion develops, as mentioned previously, such as ACTH, PTHRP, calcitonin, GHRH, etc., and usually associated with poorer prognosis. The histopathological diagnosis in gastroenteropancreatic neoplasms and also specifically in insulinoma patients have to follow a very detailed list of topics to be addressed by our pathologists, starting with the immunohistochemistry, staining for specific neuroendocrine markers such as chromogranin A and synaptophysin, and of course, specifically for patients with insulinoma, staining for insulin. The morphology of the cell, which is helping us to classify the tumors in well-differentiated or poorly differentiated, as you'll see in a minute. Staining for Ki-67 proliferation index and counting the areas of the highest nuclear labeling for these cells. Looking at mitotic count, which is mostly important for the thoracic neuroendocrine tumors, and also evaluated some other factors related to tumor aggressiveness, such as vascular invasion, the presence of necrosis, or other stainings as listed here. And this is practically the last WHO classification used for these tumors, including for insulinoma. And as you can see here, we have two main categories. The most frequent one, as I highlight by my mouse here on the slide, that the neuroendocrine tumors, NET, and about 10 to 50% are represented by NEC or neuroendocrine neuroendocrine carcinoma. All of them belong to neuroendocrine neoplasm. So insulinoma can be either NET or NEC. And you can see that inside the neuroendocrine tumors, we have three main categories based on the morphology of the cell and the Ki-67, if less than 3% well-differentiated grade 1 NET, between 3 to 20% well-differentiated grade 2 NET, and more than 20% with good morphology, well-differentiated neuroendocrine tumor grade 3. Sorry. And insulinoma can belong to each of these meaning that insulinoma can be grade 1, grade 2, grade 3, or a poorly differentiated tumor. So the therapeutic decision in our patient is based on the type of the tumor, on the stage, and on the grade by the classification that I've shown to you, by the extent of the spread of the tumor and liver involvement, by the functionality of the tumor, importantly, by patient performance status, and last but not least, by availability of a variety of treatment modalities. And usually during their lives with the disease, most of our patients receive a combination of different treatment modalities. Now, focusing specifically on insulinoma, this is the most common functioning pancreatic neuroendocrine neoplasms with an incidence of about 3 new patients per million people per year. And most of these tumors are well differentiated, meaning either grade 1, grade 2, and rarely grade 3 neuroendocrine tumors. And usually insulinoma follow the rule of 10, meaning 10% of these patients have multiple tumors or have malignant tumors or have tumors developing inside MEN1 or having a tumor in an ectopic location, such as not inside the pancreas, but for example, in a lymph node nearby the head of the pancreas. And we should suspect these tumors when the patient presents with what is called Whipple's triad, including symptoms of hypoglycemia in the presence of low glucose level, usually less than 40 milligram per deciliter or less than 2.2 millimole per liter, and relief of these symptoms with glucose administration. Now, what are the symptoms of hypoglycemia? These can be divided in either autonomic symptoms such as adrenergic one, including palpitations and tremor, or cholinergic one, including sweating, hunger, or paresthesia. The neuroglycopenic symptoms include weakness, as well as psychiatric and neurological manifestations. Many times our patients come with behavioral changes, confusion, agitation or blurred vision, seizures, or transient loss of consciousness, ending to the extreme of these symptoms represented by hypoglycemic coma. And this coma can be sudden with agitation, hypothermia, and sometimes pyramidal signs, but it may be also profound and prolonged, and therefore may cause neurologic and long-standing cognitive sequelae, leading to sometimes to brain death. So the combination of the autonomic and neuroglycopenic symptoms strongly suggest in the right setting and context the diagnosis of hypoglycemia. The hypoglycemic spells typically occur after a period of fast. We are always asking our patient if the symptoms appear after a long fasting. However, these symptoms related to hypoglycemia can develop several hours after the last meal, or sometimes after physical exercise, or sometimes they may occur within hours following a meal or even without any relationship to the meal time. So very importantly, symptoms occurring in non-fasting patients do not rule out insulinoma. For example, I just brought to your attention one of the studies published recently evaluating a series of 214 insulinoma patients. And they actually summarized the appearance of symptoms of hypoglycemia in about 73% exclusively in fasting state, followed by both fasting and postprandial state in about 21%, and in postprandial state only in 6%, as well as reporting on weight gain in up to 25% of the patients. And interestingly and importantly, for the rare pregnant patients with insulinoma, symptoms in these young ladies may mimic those of emesis gravidarum in early pregnancy, and they may disappear in late pregnancy because of the development of insulin resistance as these women progress in the pregnancy, and then these symptoms can return actually after delivery. So the differential diagnosis of insulinoma is really broad because the symptoms are non-specific and can mimic other pathological conditions. And a major distinction has to be made from patients with what is called non-insulinoma pancreatogenous hypoglycemia, including a negative screening for oral hypoglycemic agents and evaluating insulin antibodies to rule out that the patient did not factitiously injected insulin. And here I brought to your attention at a glance the differential diagnosis of endogenous hyperinsulinemic hypoglycemia, and will not look at the congenital part, but will focus mainly on the acquired part of the reason. And you can see here, it can be produced by in the setting of postprandial time in patients with dumping syndrome, post-gastric bypass surgery, in patients with insulinoma, but are other diagnoses that can should be ruled out, such as use of specific drugs or factitious use of oral antihypoglycemic drugs, such as sulfonylurea, etc., as well as to rule out adrenal insufficiency in these patients. So the diagnosis really need a high index of suspicion in the clinical context that is suggestive in the presence of low blood glucose, usually less than 40 milligram per deciliter, in the presence of a high, inappropriately high, actually insulin and C-peptide, whereas the gold standard to diagnose insulinoma is practically the 72-hour fast test. And I will discuss this briefly in a few minutes. So starting with the glucose, the measurement of plasma concentration of glucose is mandatory, of course. Ideally, this should be performed during the symptoms. And the most valid evaluation actually is to perform plasma glucose by using the venous blood sample and not the glucocheck of the patient with using a reliable laboratory method. The threshold to define hypoglycemia is controversial, but it should be at least 55 milligram%. However, the glycemic threshold can cause clinical symptoms is very heterogeneous about a variety of individuals, and usually a plasma concentration of glucose of less than 70 milligram per deciliter at the time of clinical symptoms is thought to be enough to warrant further investigation. This doesn't mean that the patient has an insulinoma, but at least indicates the need for further investigation. Another mandatory requirement for the diagnosis of insulinoma is to provide evidence for inappropriately insulin secretion at the time of hypoglycemia. And how can we do this? So the diagnosis can be made when serum insulin concentration is at least or higher than 3 milliunit per liter, in the presence of serum C-peptide concentration more than 0.6 nanogram per ml, and if available, we can use also serum proinsulin. And during a fast test that I will discuss in a moment, beta hydroxybutyrate levels that are lower than 2.7 millimole per liter and increase in plasma glucose of at least 25 milligram per deciliter after administering glucagon at the end of the test indicate mediation of hypoglycemia by insulin, because insulin is known practically to suppress ketogenesis, and therefore a progressive rise in the beta hydroxybutyrate level was practically found to rule out the diagnosis of insulinoma in the setting of a 72-hour fast test. So, few words about the 72-hour fast test, which I mentioned is the gold standard for diagnosis of insulinoma. is practically believed to be one of the most robust standard tests used for biochemical diagnosis of insulinoma. It is performed usually in hospital setting, at least for 48 to 72 hours. The absence of hypoglycemia after 72-hour fast should exclude the diagnosis in most of the cases. Most of the patients develop symptomatic hypoglycemia in the first 48 hours, usually if they have insulinoma. This test has a high sensitivity, meaning that a normal test result should be interpreted in the light of symptoms, and there is a detailed protocol that I will not go into it because of shortness of time, but it's written here and it is widely available. And this test practically is stopped when either Whipple's triad is observed or plasma glucose concentration drop below 55 milligram per deciliter in a patient who had previously experienced the Whipple's triad, and if plasma beta hydroxybutyrate levels rise above 2.7 millimole per liter. The glucagon test is used at the end of the 72-hour fast test, and an increase in plasma glucose of at least 25 milligram per deciliter after IV glucagon suggests insulin-induced hypoglycemia. And this test is really important to be performed at the end of a prolonged fast test. At the time of symptomatic hypoglycemia with concomitant plasma glucose concentration of less than 45 milligram per deciliter, or after the test of 72 hours, and measuring practically plasma glucose after the administration of glucagon, a 10 minutes interval for about 30 minutes, showing increase in the levels of glucose, indicating insulinoma. So we have a summary regarding these recommendations or criteria for diagnosis, for the biochemical diagnosis of insulinoma, as published by the European Neuroendocrine Tumor Society. And when you look at these guidelines, they recommend practically to follow 6 strict criteria: a documented blood glucose of less than 2.2 millimole per liter or less than 40 milligram per deciliter, a concomitant insulin levels more than 6, C-peptide levels more than 200 picomole per liter, proinsulin levels more than 5 if available, hydroxybutyrate levels low than 2.7, and absence of sulfonylurea or sulfonylurea metabolites in the plasma and in the urine of the patient. And further testing should include the 72-hour fasting, which is the gold standard for establishing the diagnosis of insulinoma. Now, in the moment that we have the biochemical diagnosis, then we should refer the patient to perform an imaging. Only when we have a biochemical diagnosis done. And why is this? Because in the population, in the regular population, the presence of incidentaloma also in the pancreas can be seen in at least 10% of the patients. So this is not so rare. And the role of imaging is practically to localize and to stage the tumor prior taking the treatment decision. The majority of insulinoma are solitary and intrapancreatic located, and they are characteristically small tumors, mostly being less than 2 centimeters, and most of the time difficult to localize radiologically. So in clinical practice, there are 2 different modes of localizing techniques. The first group include preoperative localization, either non-invasive studies, usually 3-phase CT of the abdomen, or functional imaging. And here I would like to mainly stress the exendin PET-CT, which has a very high sensitivity and specificity for these tumors. And if these methods fail to localize the tumor, so there are invasive studies that can be used, such as most frequently endoscopic ultrasound, and nowadays rarely the selective intra-arterial injection of calcium with hepatic venous insulin gradient measurements. We have also intraoperative modalities that usually include palpation of the pancreas by the specialized surgeon and intraoperative ultrasound examination of the pancreas. And these are practically believed to be the best methods to detect insulinoma. And this is just an example of a summary of the literature regarding the detection rates of insulinoma by type of diagnostic modality. You can see here the mean detection rate by CT in about 83% of the patient, MRI 87%, PET-CT with somatostatin receptors in only 52% because of the expression of somatostatin receptor 2 only by about 50% of the patients, and mainly patients with malignant insulinoma. And as mentioned previously, the exendin or GLP-1 receptor exendin PET-CT, which has a very high rate of detection up to 98%, and very useful. However, unfortunately, the availability of this PET-CT is relatively limited. And this is an example from our clinic of a patient with metastatic insulinoma. Here you see the FDG PET, and here you see the gallium dotatate PET. And you can see practically this is the primary tumor here, and different metastases in the liver that are either uptaking on FDG and or on gallium dotatate, showing heterogeneity practically of biological behavior of these different foci of the disease. What about treatment? So the treatment is also challenging. The treatment includes, first of all, surgery. This is practically the treatment of choice. Perform nowadays mainly laparoscopically using intraoperative ultrasound. Another option these days is the use of ablation, the radiofrequency ablation, because the insulinoma practically are one of the few neuroendocrine tumors believed that in up to 90% they have a benign behavior, and being small, less than 2 centimeters, they can be easily ablated. So usually today we consider radiofrequency ablation for small localized lesions, and mainly in patients that are unfitted for surgery. And medical treatment in patients with so-called benign insulinoma, mainly for patients who are unable or unwilling for surgery, or in patients with metastatic disease, or sometimes as a bridge between the diagnosis and up to performing the surgery or the RFA. And the medical treatment include dietary consultation together with self-monitoring of glucose at home, and sometimes the need for glucose infusion. We can recommend the use of the diuretic called diazoxide that suppress the secretion of insulin and improve the hypoglycemia within the limitation of a variety of side effects. But from my experience, for example, it can be a very useful drug. Then we can use glucocorticoids that can also help in refractory cases. And we can consider to use somatostatin analogs that also inhibit insulin secretion. But first, as mentioned before, and I will discuss this later on as treatment for malignant insulinoma, these drugs can induce a paradoxical exacerbation of the hypoglycemia via suppression of the growth hormone and glucagon, and therefore worsening the situation in some patients. And for the malignant insulinoma, we have practically all the options that we use in patients with malignant metastatic pancreatic neuroendocrine tumors with some unique characteristics for insulinoma. And I will discuss very briefly now somatostatin analog, PRRT, chemotherapy, mTOR inhibitors, and TKIs in the context of malignant insulinoma. And of course, for these patients with malignant tumor, we have to include in our treatment the supportive and palliative care, either related to pain, to bone involvement, external radiotherapy, as well as psychosocial and psychological support. So very briefly now on these various options of treatment for malignant insulinoma, and starting with somatostatin analogs. So we all know these are old drugs that have both anti-secretory effects and anti-proliferative effects. So starting with the anti-secretory effects for our patients with insulinoma, these drugs may inhibit insulin secretion through their effects on somatostatin receptor, mainly 2. However, we have to keep in our mind, as mentioned, that these receptors are present in up to between 50 to 70% of patients with insulinoma and more in those with malignant ones. Before starting, for example, long-acting somatostatin analogs in these patients, we have always to perform in-hospital test with 100 microgram of octreotide to see the response of the patient if it's not worsening the hypoglycemia. And this test practically was shown in the literature as a very good predictive test of the long-term efficacy of octreotide treatment at the long term. So somatostatin analogs can achieve normalization of plasma glucose levels in up to 60% of the patients with few adverse effects, mostly digestive intolerance, but quite easily manageable in terms of loose stools, steatorrhea, and abdominal cramps. And the dose of octreotide that was found to control hypoglycemia and insulinoma varied between 50 to up to 2,000 microgram per day. And of course, we had to decide on the specific dose for a specific patient in an individual manner. In terms of the anti-proliferative effect of the somatostatin analogs in patients with pancreatic neuroendocrine tumors, and specifically including also patients with metastatic insulinoma. So we have data coming from the phase 3 Clarinet study showing a median progression-free survival for lanreotide of up to almost 40 months versus 18 months in the patients that receive placebo. So these drugs are standard of care today for metastatic pancreatic well-differentiated tumors, including insulinoma. Now, very briefly on PRRT, or peptide receptor radioligand therapy in the setting of insulinoma. So first of all, for those of you that are not familiar with this treatment, the concept is that if we will perform coupling of a radioisotope molecule to a molecule that will specifically bind to tumor cell, we could be able to deliver an effective radiation dose treatment to the tumor. And the molecule that is the most one used today is lutetium-177 here. As you can see here, that is practically connected to octreotide, which is an analog of somatostatin, via DOTA, which is a chelator molecule. And we have a lot of data for the last decade, at least, showing favorable symptomatic and biochemical responses using PRRT. The eligibility criteria include metastatic tumors, including metastatic insulinoma, with high somatostatin receptor expression, like in this patient showed here. Most of the cases, patients with well-differentiated tumors with a very good performance status, because this treatment is administered in isolation. And there are strict contraindications, such as pregnancy, of course, breastfeeding, decrease in kidney function, or suppression of the bone marrow. And specifically, this is one of the highlights of this talk. Practically, very recently, the NETTER-2 study has been published in patients with grade 2 and grade 3, including pancreatic neuroendocrine tumors, showing the very beneficial effect of PRRT in the setting with progression-free survival of reaching up to 23 months in the group receiving lutetium dotatate versus only 8.5 months in the group receiving high-dose somatostatin analog, and it was the control group. So PRRT is really, as part of the theranostic modalities of treatment, one of the highlights of the therapies in these patients. Specifically for patients with insulinoma, we can consider also the use of everolimus, which belong to the group of mTOR inhibitors. mTOR is or known as mammalian target of rapamycin, as protein kinase that regulates cell proliferation and survival in all of our cells in the body. And it has been shown also in patients with neuroendocrine tumors as being overactivated. And everolimus is practically inhibiting this protein kinase, is an mTOR inhibitor. And it has been shown by a couple of phase 3 studies, including patients with pancreatic tumors, as prolonging the survival of these tumors. And it is approved in patients with gastroenteropancreatic well-differentiated tumors. And specifically for patients with insulinoma, this treatment is more effective than in other patients because everolimus normalizes plasma glucose levels within usually 14 days, coinciding with lower glucose uptake in the tumor and in the muscle and declining proinsulin levels. However, when we decide on the treatment of a specific patient, we have to take into consideration the tolerance, because mTOR inhibitors usually are associated with a variety of side effects, and this should be very detailed discussed with a specific patient. Tyrosine kinase inhibitors can be also used in insulinoma. Sunitinib is the classic drug that it is used in a patient with a variety of gastroenteropancreatic neuroendocrine tumors, including insulinoma. And very recently, cabozantinib, which is a new tyrosine kinase inhibitor, has been shown in this publication practically at the beginning of this year in New England Journal of Medicine as significantly improving progression-free survival in patients with advanced pancreatic well-differentiated tumor, including in patients with insulinoma. Now, briefly on chemotherapy, the aggressive one, the cisplatin and the topoisomerase usually is ineffective because the low grade of proliferation of these tumors, and the agents that can be used also in the setting of metastatic insulinoma nowadays are streptozotocin-based combination and most frequently DTIC or temozolomide. And clinical effect of temozolomide based chemotherapy resulted in objective response, including partial response and disease stabilization in up to 70% of patients with pancreatic neuroendocrine tumors, including metastatic insulinoma. And finally, I would like to share with you 3 of my patients. So this is the first one. This is a 64-year-old patient. He is a teacher, and he practically come to our clinic because of episodic confusion, speech difficulties, and blurred vision and weakness. And he performed an initial evaluation showing on the routine biochemistry glucose levels of 55 mg/cent. And then we referred him to a 72-hour fast test. And after 26 hours only, he developed symptomatic hypoglycemia with the glucose levels of 38 mg/cent in the presence of inappropriately high insulin of 130 and high C-peptide. So the biochemical diagnosis here was of an insulinoma. Then we referred him to a high resolution CT of the abdomen that demonstrated a 12 millimeter pancreatic tumor, which was biopsied during an endoscopic ultrasound. And on biopsy, the diagnosis was of a well-differentiated neuroendocrine tumor grade 1 and positively staining also for insulin. And when we look at the chart of this patient also on retrospect, and this can be really seen in quite few of our patients with insulinoma, he actually had low glucose levels already for the last 5 years that were overlooked practically by his family doctor. He started to use small meals every 2 to 3 hours, including in the nights, and started to gain weight. And actually, he performed a CT 3 years ago because of a car accident, and already at that time, the same size lesion could be already seen in the pancreatic neck. And actually, we discussed this patient in our tumor board, and we offered the patient either Whipple surgery, and we mentioned also the option for radiofrequency ablation that actually the patient preferred. You can see here on the left side of the slide the CT a few years before the diagnosis, showing this lesion in the area of the neck of the pancreas. This is the lesion on endoscopic ultrasound before the ablation, after the ablation, and this is after about more than 6 months, the residual area, hypoechoic area after the ablation. And practically, the patient was cured, the glucose levels increased, and he lost 5 kilograms under the diet, and he's continuing his follow-up. This is a second case that I would like to share with you. This is a 52-year-old lady diagnosed and initially treated for so-called benign insulinoma in another center. During her initial diagnosis in another hospital, she started practically by presenting to that hospital, to the emergency room because of confusion and like abscess spells. That in an atypical way were more prominent after meals and not during fasting. The blood test performed in another center showed a hypoglycemia of up to 29 milligrams per deciliter with high insulin values and C-peptide, and 1.5 centimeter mass could be seen on her pancreatic body on a CT scan. They also perform an endoscopic ultrasound guided biopsy that was actually non-conclusive. And the patient underwent a surgery in another center, including distal pancreatectomy and splenectomy. And the pathology report from there showed practically a grade 1, well-differentiated neuroendocrine tumor, positively staining for insulin with Ki67 of 1% and without any other characteristic for aggressiveness. And then after this surgery, she practically had no relief in the symptoms. Again, she had weakness, dizziness, headache, and low glucose levels between 30 to 50 milligrams per deciliter. As they suspected malignant insulinoma, as mentioned, malignant insulinoma usually pose increased uptake on gallium dotatate PET-CT, which is the somatostatin receptor imaging. She performed this PET-CT about 2 months after the surgery. And this PET-CT showed a few hypodense hypovascular lesions up to 9 millimeters in both lobes of the liver, but with no any uptake. Lesions were seen on the CT, but with no uptake on the PET. And we practically performed in our center a comparison with the pre-surgery CT. And actually, we could see some of the liver lesions in retrospect in the liver, but at a smaller size. We hospitalized her for a 72-hour fasting that confirmed endogenous insulin secretion persistent after the first surgery. and practically an abdominal MRI. And I brought this case because it's really unique. This patient has multiple bilateral liver lesions as seen here, all these multiple and small different size lesions in the liver with very high, the hypoechoity here is practically indicated lipogenesis, a high amount of cholesterol or lipogenesis, fat appearance inside this metastasis because of the local secretion by the metastasis of insulin inducing local lipogenesis. So this is really a very unique case. So we perform, liver core biopsy showing the same type of tumor, like comparing with the original one, positively for insulin and all the other neuroendocrine markers. The K67 proliferation index was 2%, and the background of the liver displayed marked steatosis. And we revised actually the specimen from the other hospital. And actually what was different, and this is highlighting the need for a specialized pathologist when we make the diagnosis of a neuroendocrine tumor, and in this case of insulinoma, we could see a focus of vascular invasion, and the K67 proliferation index was higher. So we discussed this patient in our neuroendocrine tumor multidisciplinary tumor board. We started with treatment practically with a local regional targeting the disease in the liver with selective internal radiation therapy with SIRT that induced a gradual clinical and biochemical improvement for about 1 year. However, after this year, there was some progression in the liver, and we started everolimus, and now she's on 10 milligrams per day with stabilization of the disease and with no hypoglycemia. And the last case that I would like to share with you, this is a 45-year-old patient that arrived to our clinic with abdominal pain, weight loss. He was diagnosed with well-differentiated pancreatic neuroendocrine tumor grade 2, metastatic to the liver with high uptake on somatostatin receptor imaging. This tumor was non-functioning at the diagnosis time, and the patient was treated with somatostatin analog followed by 4 courses of PRRT. And practically 10 months later, after the last PRRT, he developed severe hypoglycemia, as you can see here, with very high levels of insulin and C-peptide. And as you can see here, in the top image, you can see the recent somatostatin receptor imaging, and the disease was progressive compared with the previous one in the liver and in the lymph nodes. So we rebiopsy this disease, and we could see a higher K67 of about 25%, making practically the diagnosis of non-functioning pancreatic neuroendocrine tumor with transformation to insulinoma and high-grade progression. The patient was treated for a while with everolimus and then with chemotherapy, and unfortunately, he died 18 months later due to progressive disease. So as mentioned at the beginning of my talk, the secondary hormonal secretion, including insulin, can be seen in patients with metastatic neuroendocrine neoplasms, and usually exclusively in patients with advanced and progressive disease and associated with poor prognosis. So to summarize this very complex presentation, insulinoma is actually a diagnosis that needs a very high index of suspicion. It presents with a pronounced inter- and intra-patient heterogeneity because of the presence of a diversity of tumor and clones biology, clinical presentations, treatment response, and related outcomes. We have to look for increased secretion of insulin and C-peptide in the presence of hypoglycemia, and always to perform the biochemical diagnosis before going to the next step of imaging and considering treatment. And therefore, the multidisciplinary team and expertise center are really essential and mandatory for timely diagnosis in the patient, to decide for the appropriate treatment follow-up, and finally to improve the quality of life and the outcomes of the treatment and the disease in the specific patient. Thank you very much for your attention.
So thank you, Simona, for this excellent and complete overview you gave us here. Please stay with us for the question and answer session at the end of the presentation of our next speaker.